Hello everyone and welcome to Rad Chat live at UKIO. My name is Norman Jorgensen and I'm joined by fellow host
Joe McNamara.
We've got that down to a T. So we've got a lovely guest here. Would you like to introduce yourself? Please?
Surely. I'm Vlad. I'm a health economist working with the GRACE project about the enhancement of consent for radiotherapy. I'm based at Bunbury University where I work in team with Dr. Emily Holmes, who is a joint co-lead of GRACE together with Lisa Ashford. And I'm glad to be joining you guys. Thank you for having me.
Why health economics?
It's a long journey really for me. I'm originally from Ukraine and I trained to be a doctor. Everybody in my family is some kind of a neurosurgeon.
Okay.
That's what I was meant to be.
Were you a rebel? Were you like, no, I'm not doing
Yeah,
that?
kind of. Yeah, but also many things happened. When I was late in my studies, COVID happened, and in a healthcare system like Ukraine's, it wasn't a great side, and there was a lot of studying at home, and I think everybody benefited from me not joining the practice. But then also in the last year of my studies, of course, the invasion of Ukraine happened. So many things, and I thought maybe I could do something more with my life, not clinical, and that's when the opportunity came up to do a PhD in health economics at Bunbury University, where I'm still finishing that. That's taken longer than expected, and that is about not radiation, not gynecological cancer. It's about social prescribing of all things. So I've kind of closed the circle, gone from medical to kind of community health and preventative health, and now I'm just here using my skills to hopefully for the improvement in the larger NHS system.
That's where healthcare started though, is in the community.
It's true.
People born at home, and that's what used to happen. So it's a good way to go back into it. You're still helping, aren't you?
Yeah, it's nice. I'm not looking forward to joining the NHS per se. My partner is working as an F2. I think we have plenty of medicine at home. I'm fine. We'll see how I turn out, what I do. But it's good. It's fun. It's good fun. Trying different things.
What have you learned from social prescribing? Because that's a huge area that's growing because of the emphasis now on prevention.
Yeah, I've learned that it's a complex system. I think when people speak about social prescribing, they might be imagining different things. They might be thinking of prescriptions as medicines. They might be thinking, if they know a bit more about the linked workers, the connecting roles that are new, and how to actually connect people to the community assets. And then there's, of course, the side of the community-based activities normally run by the third sector, voluntary sector organizations that have their own very big stake in this and lots of strong opinions. And I've surprisingly learned that everybody I talk to seems to have strong opinions about social prescribing. And when I come in and I'm saying, I'm just a PhD student, I'm here to research this, I'm not taking any sides. It's a far more interesting field than I thought it would be.
You're not just a PhD student, you're a PhD student.
True.
PhD in itself is hard enough, don't say just.
Yeah, that's true. So no, it's fascinating, and I think from health economics point of view, my supervisor wants me to find out whether it's cost effective or not. That's a far more difficult question to answer than I can, but I am exploring people's preferences for aspects of social prescribing. And I think my biggest stake is it's been happening forever. People sending people to things. I would say if there are things to be sending people to, social prescribing will flourish. Maybe we will not need it eventually. So it's about having those spaces, having activities, having people come together and do things in the community and nature. We're just really blessed in Bunbury to have all this access to nature, to prescribing, to bodies of water. I'm not sure how it works in the cities, but that's where it comes from as well. So there must be things.
So tell us a little bit about GRACE project for anyone listening who's never heard of it.
Yeah, of course. GRACE is a cross-university project also involving many other organizations like Radiotherapy UK and North-West Radiotherapy Network about improving consent for people undergoing radiotherapy for gynecological cancer. The premise is a lot of people agree to having that treatment. They are less prepared to deal with the short-term and especially late effects of radiation, which are quite severe, maybe permanent, maybe long-lasting. The few components of the GRACE project explore different aspects of that. There is one work package that looks at the qualitative side of lived experiences for patients and carers and healthcare professionals. And my job as a health economist is to quantify that, to try to assign some numbers to how much value people place on the different risks and benefits of radiotherapy, how they trade between them, and hopefully with that support the development of new infrastructures for consent to not importantly, not to talk people out of having treatment, but provide them with the right information and support that will help make that more manageable and just be fairer and more equitable for everybody.
Such a big topic.
Yeah, it sounds like a lot.
And I suppose for other, like tumor sites and stuff, they're also looking at this as a way to understand late effects, what's going to happen, and consent, like all of it. There's so many other people who are waiting to kind of see the outcomes and how they can also implement it in other aspects. I don't know if you've had much collaboration with other people so far.
I'm thinking about it now that the skills and the tools we're using are very transferable to other cancers and other settings. In our work, we've the health economics component. We've drawn a little bit on an example done in, I'm trying to remember now, I think it had to do with the bladder cancers, where they also tried to gauge people's preferences into side effects and life expectancy and what people value more and to what extent. So there are examples happening out there. But yeah, no, gynecological cancer is proving to be very difficult because it's very diverse. It's not any one group of patients. They are different in the stages of treatment, how much treatment they've had before, stages of life when they're having that treatment, the complications, also just the side effects themselves. So it's been a real big question for us whether how specific we want this to be, or more generic we want this to be. But I'm sure that the larger methodology, just the angle of looking at it through the point of view of benefits and risks is widely applicable in all nosologies.
I just want to ask you, how do you even start when it comes to health economics? Like, what do you do? Do you just sit down and, stare into space thinking, right, how am I going to tackle this? Like, do you find it's like trying to solve a problem, or is it more mathematical?
It's, I'm not a maths background anything. I found that health economics is, I don't want to diss my colleagues for health economists. I have to be really in solidarity with everybody. It's applying the very diverse toolkit to questions of health, coming from economics, social sciences, qualitative, quantitative, mixed. We have people of all backgrounds in our department. It's ranging from hardcore economists with PhDs in economics to psychology, English literature. Anybody can do it if they get the feel for what's important. And the important thing is it's all about the benefits, the costs of anything in healthcare. And then you can read books, watch YouTube videos, but just get into the headspace of, okay, so what is this getting to people who receive it, to the system? What does it cost those who provide it and the society? And measuring that, comparing that, using different tools, exploring that, putting it all together into hopefully a message that will help build better services, provide better care.
It's the complexity of all the variables, isn't it? That's what's challenging.
Yes, but you're not doing everything at the same time. So, for example, on Grace, we're not doing more classic cost-effectiveness analysis or cost utility. We're not doing qualities. We're doing a small part of a smaller methodology within a bigger body of a toolkit. So it's it becomes manageable then, because you can look at what other people did, you can draw on your own previous experiences, innovate a little bit, build something better. It's it's a day-to-day. You survive, you learn. I'm very blessed to have a good manager. Emily Holmes has done work like this before, and I'm learning on the go, but also it's some of it is methodological, some of it is deeply philosophical, and it's nice to be in that space of thinking about these things.
Great, thanks so much for coming on.
Thanks for having me.
And we'll definitely do a longer episode once all of your PhD's done and